Welcome to Learn from the Case. How are you? We continue talking about sickle cell anemia or DREPANOCYTOSIS, a case of internal medicine, hematology this time. I divided it into two videos. This is the second video of two. I want to give you the latest information about sickle cell disease that I wanted to share in this presentation. Here I will talk about the clinic, the diagnosis, and the treatments. Clinically, can present as anemia, aplastic crisis, which are described as frequently induced by parvovirus B19 infection, or folic acid deficiency. Hemolytic crisis and sequestration crisis, splenomegaly, may occur, which may present with intense and recurrent pain in the hands and feet, caused by infarcts in small bones with painful edema in the metacarpus, the metatarsus, and foot syndrome. Infarcts can also occur in other bones, hips, shoulders, and vertebrae. Aseptic necrosis of the femoral head. Symptoms of visceral emboli, for instance, in the lungs, spleen, kidneys, renal papillary necrosis, liver, heart, brain, or spinal cord, which can lead to multi-organ failure. This may present with jaundice and also predisposes to development of gallstones. Acute chest syndrome, new lung supposities with chest X-ray, with fever or not, sometimes with other respiratory symptoms, infectious or embolic etiology, fat embolism, for instance, which can cause increased cardiac output, cardiomegaly, splenomegaly, sometimes functional asplenia, clinically with a late growth and development, skin ulcers in the ankle region, priapism, chronic kidney disease. On laboratory tests, you can see peripheral blood morphology, sickle erythrocytes, usually Howard-Shirley bodies in erythrocytes. Howard-Shirley bodies are seen with markedly decreased splenic function. A healthy spleen would normally filter out these erythrocytes. For instance, asplenia, post-splenectomy, congenital absence of the spleen. Absence due to splenectomy would be due to conditions such as hereditary spherocytes, trauma, or autosplenectomy, which is the cause of sickle cell anemia. I'll tell you more about this soon. Other causes include radiation, amyloidosis, severe hemolytic anemia, megaloblastic anemia, and myelodysplastic syndrome. You will also be able to see moderate hemolytic anemia, normochromia, with hemoglobin in about 8 grams per deciliter, elevated MCV or at the upper limit of normal. Other laboratory tests findings common to those described in all cases of hemolysis, reticulocytosis, schistocytosis, lactate dehydrogenase, haptoglobin, bilirubin, ferritin, and hemosideриnuria. Hemoglobin electrophoresis, a slightly elevated hemoglobin F concentration, 5 to 50%, absence of hemoglobin A, post-transfusion alloimmunization. The alloimmunization is the response of the body's immune system to donate blood or bone marrow or a transplanted organ. Is much more common than in other anemias, in about 30% of those affected, due to blood group incompatibilities in the antigens and antibodies. Ultrasound, a very important study that should be done to those who already have this diagnosis and are children between 2 and 60 years old, is ultrasounds. They must periodically undergo ultrasound examination of the main vessel of the brain, arteria cerebri media, internal carotid artery, to assess the risk of suffering a stroke. In them, the speed of the flow with which the blood circulates is inversely related to the diameter of the vessel. The higher the speed, the greater the risk of suffering a stroke. Preventive treatment with blood transfusion or a hydroxyurea may be relevant. Ultrasound of the heart, bone densitometry, and eye examination should also be performed at regular intervals. Laboratory samples showing signs of damage to other organs should also be tested periodically. Prevention of infection. Prevention can be attempted with vaccines against Streptococcus pneumoniae, Haemophilus influenzae B, Neisseria meningitidis, HBV, and influenza. In some places, prophylactic administration of oral penicillin is carried out at least until the age of 5 years. Administration of folic acid orally, prevention and treatment of pain, embolism should be excluded as a cause. The patient should be adequately hydrated and administered. Pain relievers, for example, non-steroidal anti-inflammatory drugs, opioids, and epidural anesthesia. Anticoagulant, vitamin K antagonist in low doses to keep INR 1 to 1.5, or unfractionated heparin. Transfusions of packed red blood cells, which reduce the concentration of hemoglobin S, preferably under 30% by hemodilution, suppression of the production of erythropoietin, and synthesis of hemoglobin S. The survival time of transfused erythrocytes is longer than their own, but it must be remembered that with repeat blood transfusions, there is a risk of iron overload leading to secondary hemochromatosis. The risk is lower if it is possible to exchange blood, as ferritin is a valuable surrogate marker for initial monitoring of iron levels at levels between 1000 and 1500. A special radiological examination with a magnetic camera of the liver and heart to be considered to better evaluate the risk of iron-related organ damage before starting chelation treatment. Partial exchange transfusion, erythrocytophoresis, eliminate defective red blood cells, thereby limiting the episode of thrombosis by reducing excessive viscosity. In case of iron overload, a treatment is carried out to reduce its concentration, as in thalassemia, which keeps the ferritin concentration at less than 2000 nanogram per milliliters. Operations in patients with sickle cell anemia are associated with high pre- and post-operative risk. It is important to prevent dehydration or hyperhydration, hypoxemia, acidosis, and pulmonary atelectasis. Before major interventions, exchange transfusion or packed red blood cells transfusion is sometimes recommended to maintain a hemoglobin level over 10 grams per deciliter and a hemoglobin S level under 30%. A specific treatment: hydroxyurea. This stimulates proliferation and maturation of latent precursors of erythropoietic system containing the gamma change, increases hemoglobin F synthesis, reduces the incidence of pain episodes and acute chest syndrome, and reduces the need of transfusions of packed red blood cells. It is usually administered at an initial dose of 15 to 20 mg per kilo by day. Response to treatment occurs after 3 to 6 months. The drug prolongs survival, but can cause myelosuppression, alter spermatogenesis, and produce teratogenic effect in the fetus. Allogeneic stem cells transplantation. It can cure the disease, indicated in patients younger than 16 years of age, in diseases of severe form and course, which are selected according to the HLA antigen of the family donor. L-glutamine and DRE consistently reduces the frequency of pain episodes in pediatric and adult patients with sickle cell disease, regardless of their history of sickle cell crisis. In 2017, the Food and Drug Administration approved L-glutamine powder for oral administration to reduce acute complications of sickle cell disease in patients of 5 years or older. The approval was based on the result of a randomized, double-blind, placebo-controlled study of L-glutamine in 230 patients between 5 and 58 years old over 48 weeks. Genetic therapies. The U.S. Food and Drug Administration approved 2 treatments, Casgevy and Lyfgenia, which represent the first cell-based gene therapies for the treatment of sickle cell disease in patients as young as 12 years of age or older. In addition, one of these therapies, Casgevy, is the first Food and Drug Administration approved treatment to use a new type of genome editing technology, signaling a breakthrough in the field of gene therapy. The reason why patients with sickle cell disease are seen in the emergency room are usually sickle cell crises. Any circumstances that reduces the amount of oxygen in the blood, low temperatures, or illness can cause a sickle cell anemia crisis, also called an exacerbation. The pain crisis, vaso-occlusive, in sickle cell disease is an episode of increasing symptoms and may consist in worsening symptoms of anemia, such as pain, often in the chest or lung bones, in the arms and legs, and sometimes difficulty breathing. Abdominal pain may be severe and vomiting may occur, so the possibility of a splenic or liver attachment should be considered. Sometimes additional complications arise, including aplastic crisis, the production of red blood cells in the bone marrow stops when infected with certain viruses, acute chest syndrome caused by obstruction of the capillaries in the lungs or infections, acute spleen or liver sequestration, a large accumulation of cells in an organ, rapid increase in the size of the spleen or liver. In children, acute sequestration of sickle cells in the spleen, sequestration crisis, may occur, causing an enlargement of the spleen and worsening anemia. Acute hepatic liver sequestration is less common and can occur at any age. So first, get the spleen bigger. Then over time, hyposplenism develops, still in children. Repeated splenic vaso-occlusion leads to fibrosis and progressive atrophy of the organ, autosplenectomy. And then you start seeing these all-showy bodies that I told you about at the beginning. Because the spleen helps fight infection, people with sickle cell anemia are more likely to develop pneumococcal pneumonia or other infections. Infections, especially viral infections, can reduce the production of red blood cells, making anemia more severe. The liver also gradually enlarges throughout life, and gallstones often form from the pigment released by fragmented red blood cells. Acute chest syndrome, that was the diagnosis in the last video, can occur in people of any age, but it is more common in children. It is usually characterized by severe pain and difficulty breathing. Acute chest syndrome can be fatal. Pulmonary fat embolism is one of the leading causes of acute chest syndrome. The heart is often enlarged, and an enlarged heart is less efficient at pumping blood to the body, which can lead to heart failure. Murmurs are common. Children with sickle cell anemia usually have a relatable short torso, but their arms and legs, fingers, and toes are long. Changes in the bones and bone marrow cause bone pain, especially in the hands and feet. Episodes of joint pain may occur, and the hip joint may become so damaged that it eventually needs to be replaced. Lack of circulation to the skin causes ulcers and on the legs, especially in the ankles, as I said before. Young men often suffer from persistent painful erection, priapism. Episode of priapism can permanently damage the penis, so that erection can no longer occur. Blockage of blood vessel causes a stroke, which damages the nervous system. In older people, lung and kidney function deteriorate. Treatment must be aggressive because the disease can progress rapidly and can be fatal. Treatment may include pain control, intravenous fluid if dehydration is suspected, antibiotics to treat the infection, supplemental oxygen, and blood transfusions. But as I said before, we must remember that with repeat blood transfusion, there is a risk of iron overload leading to secondary hemochromatosis, and that risk is lower if it is possible to do exchange of blood. And with this last, I say goodbye today. As always, feel free to leave me your comments or questions. Thank you for your attention and be very, very well.